Good afternoon, everyone. Yesterday, we have started with the new topic that is anti-hyperlipidemic drugs. And in that, we have studied about what is hyperlipidemia and what are the different familial types of hyperlipidemia. So now we are going to move forward and see the second class of the drugs that are utilized for the uh, treatment of the hyperlipidemic condition. So first class that we have studied yesterday, it is HMG coenzyme A reductase inhibitor, which we also called as the statins. Okay, so the main drugs are the rosuvastatin and the atorvastatin, and how they act, that we have studied, that they inhibit the de novo synthesis of the cholesterol in the cells. Thus, thereby, they increase the LDL receptor expression onto the cells. Thus, they, because of it, there is increase in the intake of the LDLs by these cells, and thus there is decrease in the or lowering in the circulating LDL levels. Okay, so that's the aim of our therapy, is to decrease the circulating LDL levels. As we know, LDLs can cause the atherosclerosis. Okay, so let's move forward. So this all we have studied. This is a classification. Second drug onward we are going to study, that is niacin, then fibrates, then bile acid sequestrants, then cholesterol absorption inhibitors, then omega-3 fatty acids, and the PCSK9 inhibitors, which is a newer class of drugs. Okay, so this we have studied yesterday. Now niacin or the nicotinic acid. Okay, so let's see the mechanism of action. At gram doses, niacin strongly inhibits lipolysis. Okay, in the adipose tissues. What is lipolysis? Lipolysis is breakdown of lipids, breakdown of storage form of lipids. Okay, so thereby they reduce production of free fatty acids. Okay, so liver normally uses circulating free fatty acids as major precursor for the triglyceride synthesis. Okay, so as there is reduced liver triglyceride levels, it decreases hepatic VLDL production, which in turn reduces LDL-C plasma concentrations. Okay, so it is like a indirect action. What it does, it, this drug, it reduces the lipolysis in the adipose tissue, because of which there is decrease in the free fatty acid concentration of the blood. Okay, as we know, these free fatty acids are utilized by the liver for the production of the triglycerides. Okay, so as the levels of the free fatty acids in the blood, they are reduced, the amount of triglycerides that are produced by the liver, they also gets reduced, and because of which what happens is that there is decrease in the VLDL release, as well as decrease in the circulating LDL levels. Okay, so here the this C, it, this C stands for the cholesterol. Okay, so it indicates what they are exactly carrying with them. The VLDLs, they carry the triglycerides, but these LDLs, they carry the cholesterol. Okay, so therapeutic uses of the niacin or the nicotine, it lowers the plasma levels of both cholesterol and triglyceride. It is useful in treatment of familial hyperlipidemias. Okay, so it is also used to treat other severe hypercholesterolemia, often in combination with other agents. Okay, so pharmacokinetics. It is administered orally, converted in the body to nicotinamide, which is incorporated into cofactor nicotinamide adenine dinucleotide. So you know about this NAD plus NADH, okay, that nicotinamide. Okay, so niacin, its nicotinamide derivative and other metabolites, they are excreted in urine. Okay, so adverse effects of the niacin, they are intense cutaneous flush. Flush means it is reddening, okay, which is accompanied by uncomfortable feeling of warmth and pruritus. Administration of aspirin prior to taking the niacin, it decreases the flush, which is prostaglandin mediated. As we know, the aspirin, it is a COX inhibitor, and by inhibiting the enzyme COX, that is cyclooxygenase, it reduces production of the prostaglandins. Okay, and the niacin, it causes flush due to production of prostaglandins. Thereby, by giving the aspirin, we inhibit this prostaglandin production, and thereby the flush which is associated with. So patients, they also experience nausea and vomiting and abdominal pain, not vomiting, sorry. Usual practice, nausea and vomiting, it is abdominal pain. Okay. Slow titration of the dosage or use of sustained release formulation of niacin, it reduces bothersome initial adverse effects. Slow titration means what? Slowly we have to go on increasing the dose. Okay, so it is not that if we have to give 10 milligrams of the dose, the final dose, then we will start with the 2 milligrams first. Then gradually will increase by 1 milligram, 3 milligram, 4 milligram, 5 milligram. Okay, so because of which the body gets adapted to the use of the niacin, and thus we can avoid the bothersome adverse effects which are associated with it. So niacin, it inhibits tubular secretion of uric acid and thus predisposes patients to hyperuricemia and gout. Okay, so what we have said, that niacin, it actually causes accumulation of uric acid in the body, and as you know that uric acid accumulation is associated with gout. Not always the gout, but it is associated most of the times with the hyperuricemia and some of the times with the gout. Okay, not all the uricemia conditions, they are gout, but some of the times this hyperuricemia, it can lead to gout. Okay, so that's why I said most of the times it is hyperuricemia and some of the times it is gout. Okay, so impaired glucose tolerance and hepatotoxicity, they have also been reported with the use of the niacin. The drug should be avoided in active hepatic disease or in patients with active peptic ulcer. Okay, so why they have to be avoided in active hepatic disease? Because they act on the liver or they are metabolized in the liver. Okay, so as they are metabolized in the liver, they shouldn't be used in the hepatic disease, because in hepatic disease the capability or capacity of the liver to metabolize any substances or any chemicals, it is reduced. That's why we should avoid this drug in the hepatic disorder. Okay, so moving forward to the fibrates, so we have two drugs there under, that is the first one is fenofibrate and the second one is the gemfibrozil. Okay, so let's see what mechanism of action these drugs have. The peroxisome proliferated activated receptors, that is PPAS, they are the members of nuclear receptor family that regulate the lipid metabolism. Simple. Okay. So these receptors, they are associated with the regulation of lipid metabolism. So what these receptors do, they function as ligand activated transcription factor. Okay. So upon binding to their natural ligands, that is fatty acids or the eicosanoids or the anti-hyperlipidemic drugs, these PPAs, they are activated. Okay. So then they bind to peroxisome proliferator response element, which ultimately leads to decreased triglyceride concentrations through increased expression of a enzyme that is called as lipoprotein lipase and decreased apolipoprotein C2 concentration. Okay, simple as that, nothing fancy. What they do, they when they respond to the ligand, they express a certain type of response element, that is peroxisome proliferator response element, and because of which there is increase in activity of lipoprotein lipase, which causes breakdown of the triglycerides into free fatty acids. And what they do, they decrease the apolipoprotein C2 concentration. Okay, so what is this apolipoprotein C2? It is basically like starting material or the raw material which is to be used for the production of the lipoproteins. We have the VLDL, we have the LDL. Okay, so for the production of these lipoproteins, we require it. Okay, so as the raw material decreases, the circulating levels they also decreases, and as the lipoprotein lipase expression is increased, the circulating triglyceride levels they also decrease. Okay, so this is how they act. They decrease the circulating TG levels as well as cholesterol levels, as well as they reduced the circulating LDLs and VLDLs. So the therapeutic uses, they are used in treatment of hypertriglyceridemias. Mainly they are used for the hypertriglyceridemia. They are particularly useful in treating type 3 hyperlipidemia, where there is dis-beta lipoproteinemia, in which the intermediate density lipoprotein particles they accumulate. We have already studied what happens in type 3. If you don't remember, then kindly refer to that second slide. Okay, so the pharmacokinetics, the gem fibrosile and the phenofibrate, they completely absorbed after oral administration, and they are distributed widely, and also they bound to the albumin. Okay, phenofibrate is a prodrug, so it's not an active moiety. So when it goes into the body, it undergoes some metabolic reaction and thus releasing the active moiety, that is phenofibric acid. Okay, so both of these drugs, they undergo extensive biotransformation and they are excreted in urine as glucuronide conjugates. So when I say glucuronide conjugates or conjugate itself, I mean that they undergo the phase 2 metabolic reaction. Okay, so adverse effects of these drugs, the most common adverse effect is the mild gastrointestinal disturbances. Okay, so these lessen as therapy progresses. So at the start of the therapy, the person will suffer from this. Otherwise, as the therapy goes on, it will get lesser. Okay, so because these drugs they increase biliary cholesterol excretion, there is predisposition to form the gallstones. Okay, so formation of gallstones, it is one of the probability. Then myositis, that is inflammation of a voluntary muscle, it can occur, and muscle weakness or tenderness should be evaluated. Okay, so the patients with renal insufficiency may be at risk. Why? Because the metabolites of it, they they get excreted through the urine. That's why renal insufficiency, it is to be evaluated, and we have to avoid giving this drug or reduce the dose of this drug in such patients. Okay, so myopathy and rhabdomyolysis, they have been reported in patients taking gemfibrozin and statins together. We have had discussed about this particular side effects when we studied adverse effects of statins. So if we give gemfibrozil along with the statins, then we these side effects they are prominent. Okay, so use of gemfibrozil, it is contraindicated with simvastatin, and in general, the use of gemfibrozil with any statin should be avoided. Okay, so 1 second, I'll just take a break. Okay, so both fibrates they may increase effects of warfarin, and therefore the warfarin should be monitored more frequently when a fibrate is initiated. Okay, so fibrate should not be used in patients with severe hepatic or renal dysfunction, in patients with pre-existing gallbladder disease or biliary cirrhosis. Okay, so if a patient has any of these conditions, then we should not be using the fibrates. Okay, so then we have the bile acid sequestrants. We have three drugs there under. The first one is cholestyramine, styramine or styramine, any way you can pronounce. Then we have cholestyramine and we have cholesevelam. Okay, chole or cholestyramine, cholesevelam, any way you can pronounce. So the mechanism of action of these drugs, it is very simple. As the name suggests, it is bile acid sequestrant. Sequestrants means what? They form or they make complex with the bile acids. Okay, so where these bile acids are present? In the gastrointestinal tract. Okay, so what function they play? You know it, you have studied it in your human anatomy and physiology. Okay, so what these drugs are? These drugs are ion exchange resins that bind negatively charged bile acids and bile salts in the small intestine. The resin bile acid complex, it is excreted in feces and thus lowering the bile acid concentration. Because of which, what happens? The hepatocytes increase conversion of cholesterol to bile acids, which are essential components of the bile. Okay, so consequently, intracellular cholesterol concentrations they decrease, which activates the increased hepatic uptake of the cholesterol containing LDLC particles, and thus leading to decrease in the plasma LDLC. Okay, so if you see this drug, it acts uh, in similar lines as that of the HMG coenzyme A reductase inhibitor. How in the same line I will tell you. Both of these drugs, they reduce the intracellular concentrations of the cholesterol, but by different mechanisms. The statins, they decrease the intracellular cholesterol levels by decreasing its de novo synthesis. And what these bile acid sequestrants are doing, they are increasing the utilization of stored cholesterol. And for what utilization they are increasing? They are increasing its utilization for production of the bile acids. Okay, why bile acid production needs to be increased? Because these drugs, when they are acting up in the small intestine, they are causing the excretion of the bile acids. And as bile acids are getting excreted, there is creation of the deficiency of bile acids in the small intestine. And to compensate that deficiency, the compensatory increase in the production of bile acid is initiated in liver, and thus thereby there is decrease in the cholesterol levels of the liver, increase in the expression of the LDL receptors onto the hepatocytes, and there is increase in the LDL uptake or endocytosis by the hepatocytes, and thereby they decrease the circulating LDL levels. Okay, so understand these drugs, although they are not acting on any of the cells, they are not acting on the liver itself, but they end up decreasing the circulating LDL levels. They even don't go into the circulation, they remain located in the small intestine only, but still they cause decrease in the circulating LDL levels, and which is a novel mechanism of action. Okay, so the therapeutic uses, these drugs, they are useful often in combination with diet or the niacin for the treatment of type 2A and type 2B hyperlipidemias. The cholestyramine also relieve pruritus, which is caused by accumulation of bile acids in patients with biliary stasis. Biliary stasis means what? When there is obstruction to the flow of bile acid, it leads to the biliary stasis, and it leads to this biliary stasis. It can be associated with the pruritus. Pruritus is like a itching condition. Okay, so the cholesterol, it is also indicated for type 2 diabetes due to its glucose lowering effects. So apart from the lipid lowering effects, it has glucose lowering effects also. So a diabetic person with a problem of the uh, increased cholesterol levels, this drug is an ideal candidate. Okay, so the bile acid sequestrants, they are insoluble in water and they have large molecular weights. After oral administration, they neither absorb. This is very important. They are neither absorbed nor metabolically altered by the intestine. So they remain as such. They don't get acted upon by the cells of the small intestine. They remain in their original form. Okay, so instead they are totally excreted in feces. The 100% of the this bile acid sequestration, it will be excreted in feces, but still they will do their work of reducing the circulating LDLs. Okay, then we have the adverse effect. The most adverse effects, they are GI disturbances. The reason, as they remain in the intestine only, that's why they cause the GI disturbances, and which include the constipation, nausea, and flatulence. Okay, so the cholecelvum, they have fewer GI side effects than other bile acid sequester. These agents may impair absorption of fat soluble vitamins like A, D, E, and K, and also they interfere with absorption of many drugs. For example, digoxin, warfarin, and thyroid hormone. Okay, so therefore, other drugs should be taken at least 1 to 2 hours before or 4 to 6 hours after the bile acid sequestrants. Okay, so these agents, they may raise the triglyceride levels, and they are contraindicated in patients with significant hypertriglyceridemia, that is greater than 400 milligram per deciliter of the triglycerides. Okay, then next drug we have, that is cholesterol absorption inhibitors, and the example is ezetimibe. Okay, so this ezetimibe, it selectively inhibits absorption of dietary and biliary cholesterol in the small intestine, which leads to the decrease in the delivery of intestinal cholesterol to the liver. As the name suggests, it inhibits the absorption of cholesterol from the small intestine. Okay, and as the absorption is decreased in the small intestine, its reach or its delivery to the liver is also decreased, because of which there is decrease or there is reduction in the hepatic cholesterol stores and increase in the clearance of the cholesterol from the blood. So always understand, the liver is a main storage unit for the cholesterol. Okay, so if there is decrease in the main storage unit of the cholesterol, then what will happen, the whatever circulating cholesterol we have in the form of LDLC, it will start coming back to its home, that is liver. Okay, so these drugs, what they are doing, the ezetimibe or the bile acid sequestrant, they are reducing the cholesterol stores of the liver, and as cholesterol stores of the liver, they are decreasing, the circulating cholesterol levels, they start coming back to the liver. Okay, so the circulating cholesterol levels, they decrease. Okay, so due to its modest LDLC lowering, the ezetimibe, often used as an adjunct to the maximally tolerated statin therapy in patients with high ASCVD risk, that is atherosclerotic cardiovascular disease risk, or in statin intolerant patients. Okay, so although it inhibits the cholesterol absorption, but its action is not that potent one as compared to the other drugs. That's why it should not be used as a alone drug, a single drug for the treatment of the hyperlipidemia. Instead, we have to use it as the adjacent drug or adjunct drug to the main therapy. Okay, mostly the statins. So the ezetimibe, it is primarily metabolized in small intestine and liver via the glucuronide conjugation with subsequent biliary and renal excretion. So the patients with moderate to severe hepatic insufficiency should not be treated with ezetimibe. The adverse effect, they are uncommon with the use of ezetimibe. So in a way, it is a safe drug to be used. Okay, so we have next, that is proprotein convertase sub, subtilisin kexin type 9 inhibitors. So that is PCSK9. PCSK9 inhibitors, and the example is alirocumab, evolocumab. Okay, so you can see it is the suffix is MAB in both of the drugs, and MAB stands for the monoclonal antibodies. And what are monoclonal antibodies? You will study in detail in biotechnology. Okay, so this pro-protein converted subtilisin kexin type 9 is an enzyme which is predominantly produced in the liver. Okay, so this enzyme, it binds to LDL receptor on the surface of the hepatocytes, which leads to the degradation of the LDL receptors. Okay, so by inhibiting this PCSK9 enzymes, what we do, we sustain or we survive the LDL receptor. We inhibit its degradation. Okay, so as we inhibit the degradation of LDL receptor, more LDL receptors are available to clear the LDLC from the serum. Simple. PCSK9, what it does, it degrades the LDL receptor, and by inhibiting this enzyme, we inhibit or we avoid the degradation of LDL receptor. Thus, more receptor are available for the LDL clearance. Okay, so this is diagrammatically it is shown how this PCSK does. This is a PCSK which is bind to the LDL receptor, and it causes endocytosis of the LDL receptor and the causing its lysosomal degradation. But with the PCSK9 inhibition, what we can achieve, we can achieve more LDL receptor onto the surface of the hepatocytes, and more binding or more intake of the LDLs with it. Okay, thus reducing the circulating LDL levels. Okay, so these agents, they are used in addition to maximally tolerated statin therapy in patients with heterozygous or homozygous familial hypercholesterolemia, or in patients with clinical SCVD who required additional LDLC lowering. Okay, so when combined with statin therapy, these drugs, they provide potent LDLC lowering, that is up to 50 to 70%. Okay, so they may also be considered for patients with high ASCVD risk and the statin intolerance. Okay, just like that of the ezetimibe, these drugs, they are also to be used as adjuncts, not as a mainline therapy. Okay, so these PCSK9 inhibitors, they are only available as subcutaneous injections, and they are administered every 2 to 4 weeks. Okay, so the monoclonal antibodies, they are not eliminated by the kidneys, and they have been used in dialysis patients and or those with severe renal impairment. This is very important. Okay, so the persons with renal impairment, we can use this PCSK9 inhibitors. Okay, they are generally well tolerated, so there is no question or there is no problem of the adverse effects also. So the most common adverse effects, they are at the injection site reactions, immunologic, because these are the monoclonal antibodies, or the allergic reactions. Then we have nasopharyngitis and the upper respiratory tract infections. Okay, so next is the this one will be the last, that is omega-3 fatty acids. Okay, so this omega-3 polyunsaturated fatty acid, that is PUFA, they are essential fatty acids that are predominantly used for the triglyceride lowering. You must have heard about this omega-3 fatty acids, PUFAs, in many of the advertisements of the edible oils. Like in Saffola ad, you must have heard about this. Okay. So these essential fatty acids, what they do, they inhibit VLDL and triglyceride synthesis in the liver. Okay. So this omega-3 polyunsaturated fatty acid, ecosa pentanoic acid, and docosa hexanoic acid. Uh, these are found in marine sources such as tuna, halibut, and salmon. Okay, it is, although it is spelled as SALMON, uh, it should be pronounced as salmon, but the L is silent, so it is salmon. Okay, so approximately the 4 gram of marine derived omega-3 polyunsaturated fatty acid daily decrease serum triglyceride concentration by 25 to 30% with small increase in the LDLC and HDLC. Okay. So over the counter or prescription fish oil capsule, that is EPA or DHA, they can be used for the supplementation as it is difficult to consume enough omega-3 polyunsaturated fatty acid from the dietary sources alone. Okay, so omega-3 PUFAs can be considered as adjunct to other lipid lowering therapies for individuals with elevated triglycerides. Okay, although effective for triglyceride lowering, this supplementation has not been shown to reduce the cardiovascular morbidity and mortality. This is very important. Okay, they we cannot uh, claim that they actually improve the cardiovascular health. Okay, so most common side effects of the omega-3 polyunsaturated fatty acid, they include GI effects, abdominal pain, nausea, and the diarrhea, which are included in its GI effects, and also the fishy aftertaste. Okay, so the bleeding risk can be increased in those who are concomitantly taking anticoagulant or antiplatelet agents. Okay, so with this, we have finished with the chapter that is hyperlipidemia, and hereby I conclude with it. Okay, so that's all from my side. Thank you.